All right, so I'm going to combine Chapter 13 and then just a little bit of the information from Chapter 14, specifically the part applying to iontophoresis. And we'll practice that a little bit in lab. Mostly for ionto in lab, we're going to do a demonstration and talk about the contraindications and precautions, but hopefully it's pretty straightforward. So we're going to talk about transcutaneous electrical nerve stimulation, or TENS, for pain modulation. The alternating current applications for pain modulation are interferential current, IFC, and pre-mod, and we'll talk about those a little bit as well. The mechanisms underlying the current use for pain modulation are gate control mechanism and endogenous opioid release, and we'll talk about which settings target those individual things. Clinical applications, of course, contraindications and precautions, and then we'll talk about iontophoresis. So the learning objectives, how does modulation affect a treatment using sensory stimulus? What are you going to modulate? What parameters may be modulated? And is one any better than another? So some of the answers to those questions we might find out in lab. I want you to know how Estim is used to modify pain using a sensory response, and how it's used to modify pain using a motor response. Two different things. I want you to be able to state the indications for Estim and be able to determine the appropriate settings for each indication, and be able to state how Estim may be integrated with other treatments and modalities in a clinical setting. For iontophoresis, I want you to be able to say what is the current that's used and the mechanism of iontophoresis for drug delivery. I want you to be able to state 4 variables which determine the dosage, and state the contraindications and precautions specific to iontophoresis and why ionto might be harmful in those situations. So, of course, the regular contraindications and precautions for all forms of Estim apply to ionto, but there are some specific ones just for it. So, TENS is used to modulate pain, and it does this through either the gate control theory, where we activate, it's a sensory application, where we activate the non-nociceptor A beta nerves, sensory nerves, and they inhibit the transmission of nociceptive signals at the spinal cord level. It's that gate control again. And some settings of TENS are thought to do it by opioid release. And that's so the gate control theory, that's an ascending pain control. The endogenous opioid release is a descending pain control. So it stimulates areas in the brain that are going to activate those descending pain controls. So here's our gate control. We have our A delta and C fibers. Those are our nociceptors sending a pain signal up to the thalamus. The A beta fibers are activated, and they stimulate an inhibitory neuron, which closes the gate, basically. So that all happens in the dorsal horn of the spinal cord, so the pain doesn't get to go past there. Gate control via conventional TENS. Conventional TENS means high rate TENS. That's another name for it. So it's a short pulse duration, 50 to 80 microseconds, and a high frequency, 100 to 150 pulses per second. IFC, interferential current, is an alternating current application. There's no pulse duration because it's alternating current. The frequency for IFC is usually 80 to 150 hertz, or pulses per second. And the amplitude that we use on both of those is to produce a comfortable sensation only, without muscle contraction. We're going to modulate either the pulse duration or the frequency or the amplitude to limit adaptation to the stimulus. TENS, or the gate control method or IFC are most effective when the stimulation is applied. So it can have short-term effects while it's on. Once you take it off, it doesn't have ongoing effects. So the opioid release via low rate or acupuncture-like TENS, it is repetitive stimulation of motor nerves. So the high rate TENS is so high that it doesn't feel like, you can't feel the individual pulses. With low rate TENS, it almost feels like a tapping, and you can feel the individual pulses. And you're actually, rather than trying to stimulate sensory nerves for a gating effect, you're trying to stimulate motor nerves. So the idea is when these motor nerves are stimulated, it stimulates endogenous opioid production and release from the midbrain. And it may result in tolerance of the pain. It can be effective for 4 to 5 hours after you end the stim session. So basically, we had a short duration pulse because we're going for sensory with the conventional TENS. With the low rate TENS, we have a longer duration pulse because we're going for motor stimulation. So 100 to 300 microseconds, and low frequency, 2 to 10 pulses per second. So with the conventional TENS or the high rate TENS, we were going in the 100 to 150 pulses per second range. This is much lower frequency. So 2 to 10 pulses per second, you can feel each little pulse. You're usually you're going for tiny little muscle contractions, so you don't usually use it more than 30 minutes at a time to avoid delayed onset muscle soreness, because those muscle contractions, the muscle's going to fatigue. So with burst mode TENS, it's another setting on TENS, the stimulation is delivered in bursts or packages. It's the same mechanism as low rate TENS, so to stimulate the release of endogenous opioids. And it may be more effective since more current is delivered. There are also low rate settings on interferential current that you can use in the same manner. So the picture on the top is the conventional high rate TENS, and it's just sort of your continuous pulses at 80 to 150 pulses per second. The second picture is the low rate TENS, and it's at 2 to 10 pulses per second. And the third picture is the burst. So you have a burst of pulses and then an interval, and then a burst of pulses and an interval. And it has a similar effect to the low rate TENS. So for acute pain, electrically stimulated muscle contractions are found to help with postoperative pain. They might reduce your need for analgesic medication. For chronic pain, they can help with non-surgical management of knee conditions such as osteoarthritis, rheumatoid arthritis, and patellofemoral syndrome. So contraindications and precautions are the same ones that we've talked about for all electrical stimulation. Additionally, you do not want to use motor level electrical stim when muscle contraction may disrupt or delay healing, such as a muscle or tendon tear. You could use the high rate TENS, but you don't want to use motor level electrical stim. So the electrode placement usually is done to surround the area of pain. So when you're using a quadrupolar setup, like in this picture, with TENS, you're using 2 channels, 2 electrodes per channel. And it doesn't matter if the channels cross. With IFC, you're also using 2 channels with 2 electrodes per channel, and you do need to have the channels cross. So that's important in the setup for IFC because of the way the alternating current works. So you can also use a bipolar setup, especially if it's on an area with that has smaller area where you don't have room to put 4 electrodes. And then you still use the electrodes to surround the area of pain, but there are just going to be 2 of them. Premodulated current is the 2 electrode 1 channel version of IFC. And so you'll use a bipolar setup and you'll still surround the area of pain. Usually I'll use pre-mod if it's on a smaller area where there just isn't room for 4 electrodes, like a foot or an ankle. So here's an upper back, upper trapezius sort of electrode placement with tens. So you can see the little tens unit on the left there. With this one, it doesn't matter if the channels cross. If it were IFC, then we would want to make sure the channels were crossed. So for conventional high rate tens or for IFC, you're going to use 100 to 150 pulses per second. For the frequency, 50 to 80 microseconds pulse duration. Sensory, you're going to turn up the amplitude not to get muscle twitches, but just to get a sensory effect. And you want to use it whenever there's pain. So if people are using a TENS unit, they can do it at home. Low rate TENS, or there's a low rate setting on IFC as well. It's less than 10 pulses per second. Higher pulse duration, because we're going for motor, 200 to 300 microseconds. We're looking for small muscle contractions, twitching almost. And you're going to do it a maximum of 20 to 30 minutes every 2 hours. So low rate versus high rate TENS. The duration for conventional high rate TENS, the duration of the effect is it's only while it's on. Low rate TENS can last 4 to 5 hours after treatment. The high rate TENS is sensory only, and so there's not really a safety issue with it. That's why you can use it all the time. With low rate TENS, there are risks of muscle soreness, delayed onset muscle soreness, because you have that muscle contraction going on. The typical conditions that you'll use conventional TENS for are acute injury and repetitive strain. And low rate TENS you'll often use for chronic conditions. You want to avoid low rate TENS for repetitive strain injuries because you don't want to keep straining it. You don't want to have those muscle contractions. Conventional TENS, you can wear a TENS unit all day if you wanted to. There's no limit to the duration of application. Usually just the limit is how much time you have to do it. Low rate TENS, you don't want to do it more than 20 to 30 minutes. So iontophoresis uses direct current, low amplitude direct current, to facilitate delivery of a drug transdermally. So it's another one of the ionic effects. It's based on the principle that like charges repel. So most commonly in PT, it's used to apply dexamethasone, which is an anti-inflammatory corticosteroid. And the drug penetrates a few millimeters into the skin. So the areas where you're mostly using it is where a few millimeters of drug penetration are going to make a difference, like epicondylitis at the elbow, or tenosynovitis at the CMC joint, or around the ankles. A lot of times iontophoresis is used. So if you have an area with thicker tissues, your target tissue is thicker, ionto is probably not going to be your best choice. So this is the current amplitude and treatment duration for iontophoresis. So the current amplitude, it depends on the patient's tolerance. If so, you want it to be 40 milliamps per minute. So if the person can only tolerate 1 milliamp of amplitude, the treatment time is going to have to be 40 minutes. If they can tolerate 4, then it's only 10 minutes. So it really has to do more with your patient's tolerance than anything. There is another low voltage ionto application, which is a 24-hour iontophoresis patch. And actually in the clinic where I work, that's what we use the most for iontophoresis. So basically it's like a big Band-Aid, and it has 2 electrodes and a battery pack embedded in it. You inject the medication into one electrode, and you put sterile saline in the other electrode, and you put it on the person like a Band-Aid, and they leave it on for 24 hours and then they take it off. Hybrid has a little machine, as in this picture, and you put the little machine on and then you take it off after 24 hours. So I'll have a couple of examples of those in lab, and then we will have the unit, which looks like a little TENS unit, that we do the 10 to 40 minute application in the clinic. The only time since in the last 10 years that I've used the iontophoresis unit is for someone who had some impaired sensation, and so we wanted to monitor it really closely. So rather than sending them home with the 24-hour patch, we did it in the clinic so we could monitor it closely. So the parameters are the electrode placement and size. The active electrode is going to be over the area of inflammation. So dexamethasone has a negative charge, so we're going to put it on the negative electrode, and that will be over the area of inflammation. The electrode size is so the current density does not exceed 0.5 milliamps per centimeter squared. And the polarity is the same as the active ion on the drug. So dexamethasone is negative, we put it on the negative electrode. So the standard contraindications and precautions for all electrical stimulation apply to iontophoresis. But additionally, iontophoresis should not be applied after the application of physical agents that might alter skin permeability, like heat, ice, or ultrasound, because that's going to change the delivery of the drug. You also need to pay attention to contraindications for the individual drug itself that's used. So, for example, the clinic where I work is a hospital-based outpatient clinic. So before we do iontophoresis with dexamethasone on someone, we have to clear it through our pharmacy department and make sure that the person does not have allergies to the drug. So the doctor prescribes it, the pharmacy department clears that they don't have any allergies, and then they send the medication to us and we apply it. So the sequence of that might be a little bit different. Sometimes in when I worked in a private outpatient clinic, the doctor would prescribe the drug, the patient would go to a commercial pharmacy to pick it up, and they would screen for allergies and everything there, and the patient would bring it with them to their PT appointment. So you need to find out how it's done in your individual setting. And you have just survived your last electrical stim lecture for this quarter. So hopefully we'll go through all of these in lab, and hopefully that will cement everything for you. And we will have electrical stim on the exam in the last weekend in November, and then it will be part of your practical exam in the lab weekend in December.